measurements if you are taking your sweep in transverse versus sagittal view, or in your proliferative phase versus the secretory phase of in, of the menstrual cycle. So how do you perfect that coronal image to get the best measurements to decide if something is clinically significant?
Well, this is, I will pass afterwards to Jean-Paul, but I just want to say this is a really wonderful question. And I think, and I don't know if, I'm sure you have the same clinical experience, but many times when we measure a septum in different situations, like proliferative versus luteal phase or transfer day, we find different images. So we try to be perfect, but perfection does not exist. And I think, and Belen can add to this for sure, uterine contractions also have a role in how the septum size, in what the septum size is. So the coronal plane definitely helps us, and we measure it, but we do see differences at different times. Also, we see difference whether we measure the septum at the time of sonohysterogram or at the time of a regular ultrasound, 3D, and that's why, you know, even if we have a septum and we know we're going to do a resection because we're decided it's appropriate to resect it, we still do a sonohysterogram because it helps in the evaluation of the size. So, you know, I think we still have a lot to learn in this, and this also is another example on how, yes, we can standardize everything, we have protocols, but then the clinical
nuances,
you know,
I don't know.
Yeah, helps. Picture is important, and it's nice. And you know, one good thing, and we'll touch it during the course of 3D ultrasound, is that it allows for us to store an image and review it with our colleagues. You know, I see something, say, Jean-Paul, what do you think? Would you operate this patient? Would you not? Etc. So Jean-Paul actually in the next talk will be telling us more about uterine malformations, and for sure he has something to add.
I think the last 4 years we are like, there's a little big discussion in what type of malformations septum operate, not to operate. I think today there's not a it's not clear, and I think it's basically because we don't classify the uterus. We in different clinics, different countries, we classify the uterus differently. So I think the more important things that we should do is to try to everyone classify the uterus at the same way, so we can know the studies that we do after that, if it have an implication or not. And for the septum, I think the best way to measure it is in a in a 3D sonohysterography, because we push a little bit the septum. It is not a very big septum, it will go up, and if it's a big septum, it will still be there with the saline solution. So we will see it in the next talks, but I think the sonohysterogram with 3D is the best way to measure the septum.
Yes.
And I think that we evaluate also vascularization during the exam.
Yes. So please, when you ask questions, introduce yourselves, Roberta Vicario and Lawrence Sadmao.
Good morning.
Okay. And Belen?
Yeah, I'm Belen Moliner from Alicante. Well, I I think I have questions for everybody. The talks were wonderful and very clarified. Well, my first question is for Peter, because you are from GE, and when I started doing 3D, I felt that the 3D was developed for obstetrician, not for gynecology. And well, you developed another softwares like SonOBC and BCI, that's very wonderful. But anyway, I like to know if you are in mind to develop some another software, because histogram, for example, for the 3D vascularization, that is very useful because we have measures. We need measures in gynecology. And the images are very impressive, but we need measures, because if not, we cannot do studies and we cannot go together. So are you developing something else to help us, like measures in a stick? And vascularization is very important for us too, in oncology too. Are you in mind to develop something like this?
Yeah, what I already, it's a really good question to say, okay, it started very nicely to make a 3D nice baby face, for example, but really we continue also in the IVF environment and also in the gynecology environment, as you could already see. Because I think also the 3D, what you already said, if you store the 3D images also for the uterus, for example, that you really have excellent information to keep it like this. But what you said already, for example, what we did, and also as a focus, okay, then I go to another field, but we also do automatic, the artificial intelligence, for example, for the pelvic floor, and also we move on and on and on, what you said also for the vascularization index. For example, with the focal, what you can do, you can already see the histogram, because that's a really good question that maybe we, in the hands-on, we can have a look at it. Because what you already said, it's not only about pretty pictures, because you also want to have an outcome, because that's also what happens, for example, for the pelvic floor. You had this very nice translabial 3D ultrasound, but now we also have developed the technology to do artificial intelligence and do the measurements automatically. So yes, I can assure you, because you can also see that Fiona is also part of the team, that she's really developing technologies together with you. So that's a really good question. So yes, it is. Yeah, it's a big focus from women's healthcare, from Polish. Yeah. And let's have a look later on for the vascularization index, because I really like the question. I could talk about 3D, 4D for the whole day. Together with Roland and Fiona, we will show.
Any other questions?
Okay, as I told you, I have questions for everybody, but I don't want to waste a lot of time. My question is for Adela first, if you want. Because in gynecologist profile, no, when you are in the gynecologist proof, no, they automatically in GE, they don't use harmonics. It's quite interesting, and you told about our harmonics and how useful are. So my question is, did you find harmonics once you started with gynecology, or direct because you use that before when you are using in obstetrician? What do you know what I mean? Because probably we are going to harmonics the professionals that coming from obstetrician.
We have harmonics in our protocols, in our gynecology protocols from the beginning before me. So I don't know if Peter can help with that, but I think they are always there, because when you turn the harmonics out, the image is very, very bad. So if you can use it, it's totally different.
I mean, you need to turn on. When you are in gynecologist profile, you have to turn on.
Depend on your protocols. You have to set your protocol.
Yeah, it's true that if you are setting your own buttons.
Yeah, if it doesn't come, but in our protocols, all of them have the harmonics. It's the contrary. You have to keep it in mind and take it out if you are not able to see something, and it will be a bad image, but at least you can see something.
Interesting that you did from the beginning because
Yeah.
I needed to change all the settings of the buttons to do that. And the last question is for Jean-Paul. I didn't know about all the papers that you show us. They were very interesting. Don't you think that we have enough evidence that antral follicles, or at least 3D measures for antral follicles, should be implied, for example, in the diagnosis of PCOS?
Yeah, yeah. I think we're now, like, I think that 3D is the present, but it will be the future because it's easier, it's quicker, and it will be more accurate, so we can have better diagnosis. And for example, in PCO, maybe we can see all the follicles, count the follicles, measure the follicles, see the distribution of the follicle, like usually is in a PCO. So there are a lot of applications with 3D ultrasound, and SonABC antral tool is a very good tool. And if you start to using it, you like it. Especially if you have a poor responder that have 3 follicles in one and 2 in the other, it won't be big difference. But if you have a patient that have more than 20 and you want to measure all the follicles, it's impressive to use the antral follicle. Y si alguien quieren hacer preguntas en español o en italiano, también las pueden hacer.
¿Recomiendan entonces hacer un screening de reserva ovárica a mujeres jóvenes y sanas sin antecedente de infertilidad?
The question is if we recommend screening in patients. I think, yeah, we recommend it because what we see is the patients go to the clinic with 40 years old trying to get pregnant for 1 year. And what they always say, if I knew there was a test to see my fertility potential, I would have done it. And it make patients explore or having a baby or maybe vitrifying the oocytes. But if they don't know, they won't do it. So I think it's important. It's controversial because it doesn't reflect really if a patient with 35 years with a poor ovarian response test and maybe stop the birth control pills and get pregnant in the next month. So we'll say, oh, I have no problem getting pregnant. But the thing is, if you wait to the 40 years, maybe you will have a problem. Maybe if it's natural, not. But if you need an IVF, your success it will be very, very lower. So I think it's important. It's something that we have to get to the people to know it, but I think it's important.
Do you think there is an optimal age to recommend it?
I think 35 years old is a good age because we have seen that 37 is a good age for doing oocyte vitrification. So maybe between 35 and 37 is the best age to make ovarian reserve test screening test.
And I just want to add one thing to this. This doesn't mean that we have to be not obsessive, but that we have to be terroristic about it. Like we don't have to say, oh, your ovarian reserve is horrible, so you will never get pregnant. Not at all. It's something like telling a woman that she's going to become menopausal because she has a low MH. I mean, I think everything has to be explained in the right way and just used in the right way. Just a question for the audience. How many of you use 3D ultrasound in your regular practice? Okay. And how many of you are reproductive endocrinologists versus general OBGYNs? Thank you. So, I think we can move to the coffee break. Thank you, everybody.